Hi, good afternoon. Thank you for joining us for the Ohio Chapter American Academy of Pediatrics Parenting at Mealtime and Playtime training. The title of this training is Mental Health, Store It Safe, Teen Suicide Prevention, Screening Tools, and Rising Stress Levels. We are excited that you're able to join us for this training, and we also want to thank the Ohio Department of Health for their support and collaboration with the Parenting at Mealtime and Playtime program. Just a few updates. So this is our last training of the Well Child Support series and the Practice Management series. We've had 4 trainings of each of those. We also have a Parenting at Mealtime and Playtime toolkit that we had just created that has nutrition and activity advice available for you, and you can register using the link there. We also have a PMP Journal Club that has 20 MOC Part 2 and 20 CME credits available for physicians. Here's more information about the toolkit. It is broken up into modules, and you can use this link there to take the pre-survey, and then I will email you the toolkit. Just a few, just little information about our PMP resources. We have age-specific handouts and topic-specific handouts for newborn through 6 years. These are on nutrition, activity, playing inside, all sorts of information. You can access those handouts on the website or on our PMP mobile app that can be downloaded from the Apple Store or Google Play. Just a few Zoom tips. Please keep your lines muted. You can ask questions throughout the presentation in the chat box, and we will get to those. Please don't share your video. And if you have trouble hearing or seeing the presentation, please let us know in the chat box and we will fix that. At this time, I will let the speakers introduce themselves, starting with Dr. Denny, and then we will get started with the presentation. Thank you again for joining us, and please let us know if there's any questions.
Great, thank you so much. My name is Sarah Denny. I'm a general pediatrician at Nationwide Children's Hospital here in Columbus, Ohio. And I have been involved in the Ohio AAP for many, many years, specifically around a lot of their injury prevention programs, as well as advocacy. I sit on the board of directors and am really excited to be here talking about one of our definite areas of passion among the group of speakers here. I'll go ahead and turn it over to Mike.
Hi, my name is Mike Gittleman. I'm an ER physician at Cincinnati Children's Hospital, past president of the Ohio AAP, and currently I serve as the AAP's District 5 Vice Chair. And with Sarah, I've done a lot of work with injury prevention, and that's what brings us here today to talk to you about gun safety. And I will turn it over to Dr. Schneider.
Hi, my name's Ty Snyder. I'm a pediatric psychologist at Nationwide Children's Hospital. I work in our Sharon Woods Primary Care Center here on the north side of Columbus in Ohio. And I'm excited to be a part of this presentation today and hopefully give you some tips and tools when you're working with some of your youth.
Hi, my name is Amy Coleman. I'm a clinical social worker here at Nationwide Children's Hospital. I currently work in Sharon Woods Primary Care, and I'm the clinical social work clinical leader for a few of the primary cares in town. And then before this position, I was on the suicide prevention team at Nationwide Children's Hospital. So this topic is definitely something, suicide prevention is something I'm very passionate about.
All right, well, I get to start things off. Next slide. As with all these talks, Sarah and I have nothing to disclose. Next slide. So really today, hopefully for our portion, I'm going to spend most of the time talking about firearm injuries and kind of why pediatricians need to discuss firearm safety. And then Sarah's going to spend the rest of the time talking about our Store It Safe program. Next slide. So a couple of the questions that we're going to ask throughout the day, we're going to ask about polling. So I just want to start with everyone that's on. What do you all think is the leading cause of death for children 1 to 24 years of age? If you want, you could just click on it and then we're going to take kind of a poll and then we'll go over it. Everybody answer?
They're still coming
All right,
in. I'll
Alex?
give them a few more seconds. There
Okay.
we go.
Excellent. So about half of you were there, and the ones that answered suicide, you were second. So do you want to go to the next slide? So it's kind of a trick question because, you know, we're talking about suicide prevention, but we always like to throw this in there. The number one cause of death by far is unintentional injuries. I mean, if you take a look at this, the left graph, that's what the CDC puts out every year. And you can see unintentional injuries cause more deaths than all diseases combined. If you actually look at all injuries, unintentional and intentional, 59.3% of deaths are the result of injuries. And suicide's the second leading cause. So those of you that said suicide, you weren't completely wrong because a lot of deaths are the result of it. I want you just to keep in mind that unintentional injuries are something that really needs to be addressed, but we're going to talk more about suicide today. Next slide. All right, next question is, what is the leading cause of death for children 0 to 19 years of age? If everyone wants to put their tally in, and then we'll look at this after. I'll leave it to you, Alex, when everyone's in.
Okay.
All right, so let's look at the next slide. One more slide. So motor vehicle collision deaths cause more deaths than all other injuries. Typically, when you think about injuries, you're looking at force causing damage to the body. And you can go to the next slide. So it's force causing damage to the body. When you take a look, the majority of people have cars. Cars go at significant speeds, and as a result, you can see motor vehicle collision deaths are the number one cause. However, when you look at firearm deaths and you start looking at suicides and unintentional injuries, about 20% of deaths are the result of firearms. And then when you add to that, that firearms are becoming more and more accessible, unfortunately, firearm deaths are continuing to increase. Like in the emergency room where I work, typically we used to see about 85 to 90% of trauma was blunt trauma and very few penetrating trauma. Unfortunately, now we're seeing more and more penetrating trauma, and actually around Nationwide Children's Hospital, gun injuries in 2020 caused more deaths to kids than motor vehicle collisions. So again, it's state by state and region by region, but gun deaths are continuing to increase nationally. Next slide. And unfortunately, if you take a look at the United States compared to other countries that have high incomes, you look at the United States has significantly more firearm deaths than any of these other countries. In fact, 91% of children that are killed in high-income countries are killed in the United States. And if you take a look, the proportions are pretty similar. Unfortunately, the homicide rates are a lot higher in the United States, and the suicide rates are also pretty high. So when you take a look at prevention, other countries are getting something right, which we are struggling with in the United States. Next slide. And so let's just take a look at some numbers, right? So firearm problem in the United States, annually there's about 1,800 deaths. As we looked at earlier, homicides are about 53% of them, suicides are about 38% of them. But if you take a look from 2013, close to 45 to 49% increase in these firearm deaths. So the firearm death rates are continuing to increase. And as I said, it used to be all motor vehicle collisions, and unfortunately these firearm deaths are continuing to increase. The sad part is suicides are happening to younger and younger children. So there's an 80% increase in suicides among children less than 14 years of age. And then unintentional injuries to firearms, there's about 6% of this population. And besides the deaths, there are also non-fatal injuries that come to our emergency departments. There's been significant increases. So in our emergency departments, there's been a 329% increase in self-harm, and in all mental health disorders, it's up about 60%. I can tell you in my emergency department alone, we used to see about 800 psych evals a year. We see close to 700 or 800 a month. So these numbers continue to increase. It's one of the reasons why we started our program that Sarah's going to talk about. Next slide. And if you take a look in Ohio, this is has just been reported by the Ohio Department of Health. This is 2019 data. And if you take a look, similar as we've just been talking about, there's been a significant increase in suicide deaths. In fact, from 2013 to 2010 to 2019, there's been a 27.4% increase. And then if you take a look at the different counties, you can see that there's no regionality to it. It's not like this happens only in rural or urban America or suburbia America, or it doesn't matter about socioeconomics. This affects everyone across all boards, across the state as a whole. Next slide. Next question is, how much does the U.S. spend on gun victims annually? What do you all think? It's a polling question. I feel like I'm on Jeopardy here. The music should be playing. All right, again, a varied response. Next slide. But as you can see, those that answered 1.4 billion were correct. And that's just on direct costs. If you add indirect costs, it's close to $19 billion. An average hospital charge is about $14,000. Now, I'm not going to get on my soapbox about legislation, but when you take a look at, so we talked about these other countries and how these other countries are doing incredibly well in preventing these gun injuries, yet we in the United States are not doing as well. And then you sit there and say, we have a problem with medical healthcare costs in the United States, and we're spending about $1.4 billion on these gunshot victims. And the saddest part about them is 81% are either publicly insured or uninsured. So when you want to start talking about any type of legislation or any type of restrictions, if we don't make restrictions or prevention up front, we as a society are still paying for it on the back end because we're paying for the cost of the care. So anything that we can do to prevent it, not only are we preventing harm, preventing post-traumatic stress, preventing mental health problems in the future, we're also preventing significant costs of care, and we could save a lot of healthcare dollars. Next slide. So I'm not going to spend much of this time talking about gun ownership or gun safety, and we'll talk more about this later on. But, you know, as I mentioned earlier, that there are a significant number of motor vehicles. In fact, many homes have 2 motor vehicles. Some have maybe 3 motor vehicles. So there's a significant number of them, and there's a significant number of people that are driving on the roads. Well, if you take a look, when you look at firearms, close to half of all homes have a firearm, which means there's about 200 million guns, and the majority of these are handguns. You know, it's state by state. So some states there are significantly more firearms, and in some states there are less. In Ohio, about 37% of households report that there's a firearm. Now, granted, this is self-reported, so that number is probably a little bit lower than what actually exists. And when they look at these families that report, 46% report that their gun was in an unlocked location. Next slide. Well, and so we always hear this question, well, why is the gun in an unlocked location? You know, I need to have access to that gun to protect myself. Well, Art Kellerman, who's from Georgia, he's done a lot of work on firearm safety. And when they do a stratified risk analysis, that if you look in an urban home, the risk of using a firearm for suicide with a gun in the home is about 5 times higher than for protection. The use of a gun, the risk of homicide with a gun in the home is about 3 times higher than self-protection. And the risk of a fatal shooting of a household member is about 22 times higher than using it against an intruder. So if you have a firearm in the home, unfortunately, you're more likely to use it either on yourself or another family member than you are in actually protecting your home from any type of violence. Next slide. And when you look at of homes who completed, or of youth that completed suicide by firearms, 82% used a gun from their house. So it's not like people are going out and purchasing guns or going out and stealing guns. Many of these teens, when they have access to something, they will use it. And when they have access to a firearm, they're typically going to use it, and they're going to get that firearm from the home setting. Next slide. So as we talked about it, that it's the second leading cause of death for teens. Unfortunately, as I was mentioning, in some areas, it's now creeped up to be the #1 cause of death is suicide in some locations. And when you tally up the numbers that we're seeing, there's about a suicide death every 3 hours, which is really sad because these are things that are 100% preventable. Next slide. So when you talk about suicide, and our speakers later on are going to talk about some programs and talk about things that we can do, but one thing when you're thinking about prevention is teens are incredibly impulsive. All right, so when they've interviewed survivors of near lethal suicide attempts, about 25% made an attempt within 5 minutes of that decision, 50% within 20 minutes, and 71% within 1 hour. And so what happens is a child or a teenager breaks up with their significant other, they have a fight, they were bullied, and their impulse, and they say, I want to do something to hurt myself. And so anything that we can do to block that lethal means, especially within 1 hour, we are actually going to save that child's life, and either they're going to change their mind or we're going to be able to get them help. So the idea of a program that we would develop would be, what we want to do is prevent access to lethal means. So ways that we can keep them to have access from a firearm, from a sharp object, from medications, things that are going to harm themselves is what we should be doing because these kids are incredibly impulsive. Next slide. So as we talked about, the presence of a firearm in the home increases that risk of suicide, even if they haven't been diagnosed with a psychiatric problem. So many of the times when you talk to families, they'll say, my child doesn't have any psychiatric issues. It's not a problem. We don't have to worry about it. Well, when they've interviewed teenagers, about 25% of teens at any given time say that they're depressed. So think about that. 1 in 4 teens at any given moment could say they're depressed. Either maybe they did poorly on a test. Maybe they were bullied that day. Maybe they aren't getting along with their spouse. Maybe they got yelled at by their parents. Maybe they're about to get grounded. At any given time, this happens. What's a kid going to do? They're going to say, I'm bad. I didn't do something right. I need to act upon that. And then they're impulsive. And so what we need to do is protect them from that firearm. Next slide. So when you look at what are some common triggers, and I mentioned some of them, and we'll go through some more. You want to click through these. So one is bullying. So and that bullying can be between peers, and it's usually repeated over time. And this can lead to lower school performance and detachment from others. Unfortunately, a lot of these kids, they might even actually do what they're supposed to do about bullying. They might go see their principal. They might go tell their parent. They might go tell another teacher. And unfortunately, they don't always get the response that they want. They might tell their principal and say, look, so-and-so has been bullying me. And the principal says, you know what, that happens all the time, and pushes them away. And when the child then tries to seek help, they don't always get it, and then they don't know what to do. Next slide. Or I'm sorry, next thing. So internet usage. So studies have shown greater than 5 hours of video game or internet time daily is strongly associated with higher levels of depression and suicidality. I mean, many people talk about this all the time. If you look at Facebook, for example, or you look at other social media posts, people always post how great their life is, or teenagers might see someone's having a party and they weren't invited. And as a result, what's it do? It lowers your self-esteem, and then it leads to depression and other problems. Next trigger. Increases in stress in home or at school. So as you can imagine, during COVID time right now, kids are not having that peer-to-peer interaction. They're actually looking at things online. They're not actually being able to socialize with their friends. They're stuck in the home. Many of them think this is never going to end. Some of these teenagers think that they might die from COVID and they're depressed. So this, just the COVID, what's going on right now, has significantly increased this risk of suicidality. Usually in the January through March months, we see a lot of kids that present with suicidal ideation and depression. And unfortunately, these numbers are significantly higher because of and COVID and isolationism that we're seeing. Next trigger. And then if they've had recent attempts, that's also a significant risk. So anybody that you have any concern about in general, you should really be preventing lethal means and them having access to it. Next slide. You can scroll through all of these. So in reality, kids are living in environments that have a firearm. When you look at the younger children, kids that are as young as 3 years of age can actually pull a trigger. And, you know, the little kids are curious, but as we talked about, these teenagers are incredibly impulsive. And because of this impulsivity, we have to make it so that they cannot get near anything that can harm them. Next slide. And so looking at the program that Sarah's going to talk about, you know, one of the problems that we talk about with firearms in general is there are differing viewpoints. And it's such a polar problem, not only in government, but also even in day-to-day in talking to friends, family, neighbors, etc. So, and I think some of this is about the way that people are describing and the way you're talking about things. So, for example, the AAP's statement has always been, the safest home is a home without a gun. So you should not purchase a gun, especially a handgun, and all guns should be removed from home, especially with a child in the house. Right. Then let's look at the other viewpoint. When you look at the NRA says the AAP's been under the control of social justice warriors. They believe that, you know, in gun prohibition, and actually their viewpoint is the safest home is a home with a firearm because I can protect myself. Now, granted, if we already looked at some of these numbers, and the numbers show you're more likely to use a firearm in harming someone else in your house or yourself than in protection, but that's the NRA standpoint, and people that have firearms have that feeling. Next slide. And then we could look at other organizations. So Doctors for Responsible Gun Ownership, they say doctors should not routinely ask their patients about guns in their homes. So if any of you remember, there was legislation in the state of Florida that said if a pediatrician or a physician asked about guns in the home, they could actually be prosecuted. That actually passed, and then it was repealed by the Supreme Court later on, but other states were looking at that. And then you look at the Children's Defense Fund, and they say you should protect children and you should not have guns. So because of this difference in viewpoints and all these numbers, next slide, we as the Ohio AAP decided we need to come up with a program. And I'm going to turn it over to Sarah, and she could talk more about the Stewart Safe program.
Great, thank you so much. All right, are you guys able to see me?
Yes.
Okay, perfect. So yes, as Mike said, the American Academy of Pediatrics policy on firearm safety says the safest home is a home without a gun. And you personally may agree or disagree with that statement. The data may definitely support that statement. But the fact of the matter is that if our families don't believe that their home is the safest without a firearm, then when we tell them, okay, you just need to get rid of the gun, that is not an effective strategy if their belief is that their home is safest with a gun. And so we started thinking about, finding common ground and these different organizations, seeing eye to eye. And we have, the AAP over here and we have NRA over here. And we were like, couldn't we just come together and agree on some basic things? Like a 3-year-old should not be able to shoot their 2-year-old in their home with a gun. Like that seems pretty, not conflictual. Like we would think that most everyone could agree on that. But nationally, that they're not in a place to have those conversations. So we decided in the state of Ohio that we would see if we could come up with our own partnership. And so we started reaching out to a number of different community partners and bringing them together, and we extended the invite. We were very intentional on who we invited, and we asked them to come together. Could we come together and have some discussion and create a partnership where we can agree on some common messaging? Next slide. And so what we wanted to do was come together and talk about gun safety in a non-divisive way. And as you guys all know, that can be very, very, very challenging. And so what we said is we just want to come up with a messaging that we can all say. And Mike Gittleman often uses the example, click it or ticket. When you say that, everybody knows what we mean. And so we wanted a statement that the pediatricians could say, and the gun retailers could say, and our law enforcement could say, and everyone would know, what we're talking about. Next slide. We definitely felt like before we had the actual meeting that we needed to have some very clear rules of engagement. And we were very, very clear that our initial goal was to talk about unintentional firearms unintentional injuries due to firearms, and suicide of teens due to firearms. We were not going to get into the discussion of a gun registry, the Second Amendment, removal of guns from the home, gang violence, or mental health issues. So we wanted to stay extremely focused on the unintentional injuries and suicide in teens. Next slide. And so, I feel like in primary care, sometimes we feel like we talk a lot about safety. We talk a lot about anticipatory guidance and how much juice they should be drinking and screens and all that kind of stuff. And at the end of the day, like, does that change behavior? What we know is when we counsel about firearms, it does in fact make a difference. So there was a study that was done where looking at pediatric practices and a different study that was done in a pediatric ED setting. And in the private pediatric practices, there was counseling done by a pediatrician on firearm safety. And there wasn't a significant difference in gun removal. So people did not say, oh, you told me to have no gun in the home, so I got rid of my gun. That did not happen. But 62% of the families in the study did improve storage in the home, compared to 27% in the controlled group. And then when a similar type of study was done in the pediatric ER setting, the physician counseled 63% did lock up or dispose firearms as compared to 0% in the control group. So when we talk about firearm safety and firearm storage, it really does affect behavior. So I would definitely encourage all of you. One of the takeaway points of this talk is talking about it really does make homes safer. So please use our materials, and I'll be sharing all the materials that are available to you. So please use those, and you could definitely save a life in your practice. Next slide, please. But we also know that education alone won't work, and that there's different layers of protection. So we do a lot of talking about drowning. And I actually noticed on the survey when it was the leading cause of death that some people had chose drowning. And that is in fact true in our 1 to 4-year-olds. It is the leading cause of death in our 4-year-olds. So talking about pool and drowning safety is really important, but there's different layers, right, to the protection when we're talking about drowning safety. And so eliminating access. So those are our barriers to the pool, the 4-sided fencing that we always talk about. Then we teach our kids swim lessons, and we talk about parent supervision. And the same thing are the layers of protection when we're talking about preventing suicide in teens. So, not having a gun in the home at all is a starting place. But if you do have a gun, then keeping it locked away. And then additionally, teaching teenagers. There's several programs out there that talk about gun safety, but the evidence is pretty clear that just teaching kids about gun safety isn't enough. We need that barrier in place. Just as we know for drowning prevention, teaching a child how to swim isn't enough. You need that four-sided fencing. A teenager may know all about gun safety, and they may know how to load and unload a gun, and they may know how to clean a gun, and they may know everything about gun safety. But if they are in a moment of crisis, that's not going to keep them from using that gun in a potentially fatal way. And so you need to have that barrier in place. Next slide. Okay, so what do parents really want to know from us? There was a study done regarding anticipatory guidance around gun safety, and what families wanted to know is, what age should firearm safety be discussed, and how do you discuss it? And how do you discuss it with the families of kids where your child may be going to play? So their friends' parents. So we're going to talk a little bit about that here coming up. And I would go next slide. The other thing, when we brought our partnership together, what we learned was that there was definitely some distrust of the medical community. And that sometimes gun owners feel judged when they're at their doctor's office, and when we're asking about guns and gun ownership. There's also a fear that the EMR is being used to develop a registry, and then that registry will then be data mined when the Second Amendment is revoked, and that data will be used to remove guns from the home. But the other thing that we learned from this partnership was that people are really open to having a conversation about gun safety. In fact, many gun owners really take gun safety very, very seriously. And it's all in the approach as to how we talk about it. They also taught us that gun boxes are more protective than cable locks. And so for our particular pilot, we used gun boxes based on the guidance from our gun safety experts. Next slide. So, one of the things that parents wanted to know was, when do you start having this conversation? I don't know if you remember the slide that Mike showed of the little baby finger holding onto an adult's finger, but the fine print on that poster says by the time a child is 2 years old, they're strong enough to pull the trigger of a gun. So I would definitely say that by 2 years of age is when you want to start having this conversation. Think about your 2-year-old. They're curious, they're very mobile, and they can find anything, and they're strong enough to pull a trigger. So talking about safe gun storage, definitely by that 2-year visit, is really, really important. And then how to bring up that conversation is an issue that we hear a lot of pediatricians ask us. Like, I don't want to ask it in a way that is off-putting to my families. I don't want to, put our relationship in jeopardy. But if you just make it part of your normal safety conversation and roll it in the way you talk about medication storage and smoke detectors and car seats and water safety, it's just the things we talk about when we're talking about safety in the home. And then the other thing that we learned from this partnership and talking to a lot of people, we had pediatricians who were gun owners, we had pediatricians who were non-gun owners, moms who were gun owners, moms who were not. And they said, really just assume everyone has a gun in their home. Instead of, do you have a gun? Saying, if there's a gun in the home, is it locked up? I know when we're talking about asthma, for example, and we're trying to figure out how often they're missing their controller medicine. When we ask, do you miss your controller medicine? It's a little more judgy than, how many times in a week do you think you miss your controller medication, right? That kind of implies, I get that you miss your controller medication. It kind of allows some permission there, but allows you to open the door for more real, genuine conversation about how often they're really missing the controller medication. What are their barriers to their controller medication? And the same things with the gun. Instead of the do you have a gun question, which can be, pardon the pun, really loaded, you saying, if there's a gun in the home, is it kept locked up? It just opens the door to the conversation in a more productive, less judgmental way. And if they say, yes, it's locked up, then great, a great opportunity for positive reinforcement and potentially kind of an opening to having a conversation about other places where the child may spend some time. If they say no, the gun is not locked up, there's a great opportunity for education and a gun box. And if they say, well, we don't have a gun in our home, so we don't need to talk about it, correcting that misconception, because chances are when we look at the data that the child is spending some time in a place where there's a gun. So maybe it's at a friend's house, maybe it's at a grandparent's house, maybe it's the babysitter's house. So regardless of whether or not that family that is sitting in front of you has a gun, gun safety is still really, really important. And I cannot emphasize enough that discussing gun safety is not enough. You have to have that barrier in there in the case of, in a teenager, impulsivity, and in a child, in the event that they find the gun. Next slide, please. Okay, so after a lot of conversation and really, really great back and forth and feedback, we came up with Store It Safe. And this is our messaging. We felt like it was very simple. It was something all of our organizations agreed on. And, it was pretty self-explanatory. If you have a gun, just store it safely. It's that simple. And so we came up with these handouts. This is the first wave that we did was really geared towards those younger children, the kids that are mobile, the kids who get into everything, as you all know. So we really focused our first round of efforts around that younger age group. And so we came out with this handout, the one on the left that is the family handout. So this is a resource that you can hand to families. It's very self-explanatory, but also includes additional resources if the family wants it. And then we also developed one for physicians, because we know that physicians are not great about talking about gun safety. And it's just like anything else in anticipatory guidance. If you're not comfortable talking about something, you're going to talk about it less. So if you're not comfortable talking about child passenger safety, that's probably not the one that you're going to choose to talk about. But we know it's really important for us to talk about gun safety. And so we want to equip our physicians to be able to do it in an effective, productive manner. And so we came up with this handout that goes over the tips that I just went over with you, as well as some additional resources. Next slide. Okay. And so, as I said, that first round, we were really focusing on the less than 5 age group, and we created those 2 handouts. And then from this partnership, it just kind of started evolving and growing and gaining momentum. That was really, really exciting. Our partners were really excited that we had brought this group together. I know Buckeye Firearms, when they came to our meeting, they said, we've been trying to get this conversation going for so long. And so we're so glad to be a part of this. And so from that, we started getting funding, and people wanted to donate money towards this cause. And with that money, we were able to, through another one of our partners, buy gun boxes at wholesale. And so we decided that we were going to distribute gun boxes at the 2- and 3-year well child visits to any families that were interested in gun boxes. And so our initial funder was Kiwanis. And so they specified different neighborhoods within Columbus where they wanted the gun boxes distributed. And ironically, that is also where Nationwide Children's Hospital had several of their clinics. And so we worked together to partner with Nationwide Children's primary care to, at a few of the specific sites, do this pilot where we would distribute these resources in the gun box distribution. And then those families or those clinic sites that participated in this, all families received a survey at the end of the 2- or 3-year visit. Whether they took a gun box or not, they still received the survey. Next slide, please. Okay, and the data, and the research methodology is not awesome, because not every single family got offered it, but still the data that we did get back was so fascinating, because if you think back to what is our message, the only thing we were asking pediatricians to teach was store it safe. If you have a gun, store it safely. So one of the things we were really excited about is that many of the pediatricians, most of the pediatricians, I should say, who participated in this pilot study did in fact talk about gun safety. Next slide. But to me, this slide is what really has opened my eyes to how important it is that we talk about this. Did you learn something new about gun safety at your visit today? 50% of people felt like they learned something new about gun safety. The only thing we're teaching people is store it safe. So that was new to 50% of the people we talked to. So again, super, super important. Next slide. The other thing we wanted to figure out is, where do people want to learn about gun safety? Mike referenced the lawsuit in Florida where a physician asked about gun ownership, but 48% wanted to hear about it from their provider. And if you think about it, we are the trusted source of information for a lot of things related to kids. And so I do think that they value our opinion, they value the information we provide. So that was a really helpful piece of information. Go ahead. So 62% of the people who took the survey did take a gun box on the day of their visit. Next slide. And if they did not, the reason why is because they didn't own a gun and didn't feel that it would affect them. We definitely did provide guns. If the family said, oh, we don't have a gun, but my mom who watches my kids has a gun, can we have it for her house? Absolutely, then they were still given a gun box. Next slide. So then if they did take one, what was the use? And I'll show you a picture of the gun boxes in a minute. They were mobile, so you could use them in a car or in the home. So 81% planned on using it in the home or car. Next slide, please. Okay, and so phase 2, which we just most recently rolled out last November, is more focused around teens and really focusing on prevention of suicide. Next slide, please. Okay, so what can we as providers be doing during the visit? So we've developed this, well, we have kind of laid out a 4-step process. The first one is to screen for suicide at every adolescent encounter using a validated screening tool. And we'll talk a little bit more about what those validated screening tools are, whether it's a PHQ-9 or an ASK or whatnot. And we'll kind of walk through a little algorithm in a minute, but it really should be done at every adolescent encounter. And then A is for advising all families to use a barrier to store potentially lethal means safely. And I will tell you from personal experience, I have been shocked about the number of families when I used to work in the emergency department where the child comes in for suicidality and I ask about firearm ownership and the family says, yes, but we have a gun safe. Great, but does your teen either have the key or have the combination of the gun safe? Yes. Okay, well, then they still have access. So it's really about eliminating that access. The other thing that we'll talk a little bit more about is we don't want to just focus this message toward children or teens who have known mental health issues or known depression. Really, we know that any teen can be at risk. And so this advice should be for all families, not just your families where you've identified some depression. Okay. And the F is for families. So family discussion should definitely be encouraged for every teen. This is definitely an ongoing conversation. Families should be families should be having ongoing check-ins with their teen. As we all know, things can change dramatically from one day to the next, 1 hour to the next. So those frequent family discussions are important. And then E is for emergency, and that should be in the event of a life-threatening concern. And then obviously providing a lockbox if you have that available to you, and providing handouts as well, which we'll share those with you in a few minutes. Okay, so this is a busy slide and you don't need to read the whole thing. This is just an example of one of the handouts that we have available for you. So we made, for the teen wave, we made 3 handouts. One is for providers of teens, one is for families with teens, and one is for the teen themselves. This one is a screenshot from our provider handout. And as you can see, it just sort of walks you through a potential flow diagram for your clinic. So when the teen checks in for a well child visit, they complete some sort of screen, a validated screen for depression. So in this example, we're using the PHQ-9. If the patient screens positive, then you assess for lethality, and you can use the Columbia or the ASQ for assessing lethality. Then based on the scores of those screening tests, then you assess your lethality concerns and then take appropriate action. So if you feel like there is immediate concern, then you would you send them to the emergency department. If you feel that it's mild or not immediately lethal, then you would provide the family with resources, and with the moderate risk, you would come up with some kind of treatment plan, whether it's counseling, medication, or psychotherapy. And Dr. Schneider will go through those all in a few minutes. But then we want to make sure, if they're in that mild or moderate category, that they have some very close either in-person or phone follow-up, just to kind of check in and make sure that things aren't getting worse. And then if a child screens, or teen, I should say, a teen screens negative for depression, again, going back to that, making sure that every family knows how important the barriers are. And then again, the family discussions. Next slide, please. Okay, so these are the resources that we have for teens. This is a front and back document, again, also available on our website, that talks about, you know, the data, why it's so important that we're talking to our teens, talking about how important barriers are. And we, this, the box at the bottom with the red and the yellow talks, I know you can't read that, but it talks about barriers, not just for guns, but, you know, Tylenol, right? We all know that the potential lethality of Tylenol. So, you know, not just locking up our guns, but locking up medications, locking up alcohol, and being careful about barriers for all different risk factors there. And then, you know, should I talk to my child about mental health and suicide? Yes, no matter what, no matter if your child has a history of depression or not, no matter if your child has a history of SI or not, it is really important that we're talking to kids. And then, you know, giving parents some warning signs of what they should be looking for, and then some resources down at the bottom of that second page. Next slide. All right, and then for the teens, this is like a rack card that we worked on with teens, and we got a lot of feedback, and we went through multiple renditions of this card. But really what it breaks down to is giving them some resources. We know that teens are much more likely to text if they are in trouble than to make a phone call. So we have that crisis text line available to them. Some things kind of framed to, if your friend is thinking about this, you know, what they can do, but also, you know, hopefully some insightfulness that, you know, also if they are feeling this way, you know, things that they should look for, ways to keep a friend safe, and then also 10 ways to take a break. We just recognize that life is stressful, and now more than ever. And so what are some things that we can do to help promote some mental wellness and some mindfulness in our patients? Next slide. So what can you do to reverse the trend? You've already taken the first step, right? Like, you participated in this webinar on such an important topic. You can go to this link, and maybe we can put it in the chat box too, so people can really readily access it. That would be great. You can take the pledge, and the pledge just simply says, yeah, you know what, I'm going to take a step to try to do more around gun safety, and whatever that means to you, whether it means handing out the materials that we've created, whether it means just talking about it more in your practice, whether it means you apply to get some gun boxes, whatever that means for you and whatever is doable for you, that's great. The more we talk about this and the more we normalize it and make it less political, I think the better it's going to be for our young kids as well as our teenagers. So you can take that pledge. Next slide, please. So we've had lots of hospital systems also want to partner with us on our Store It Safe initiative. This is from Akron Children's Hospital. They did huge billboards where you can see that they're locking up, again, not only the guns, but also the medications and alcohol as an effort to prevent suicide among Ohio's adolescents. Next slide, please. Okay, so this is an example of the gun boxes that we provided in our pilot. And the black cable that you can see in the bottom box is a cable that loops in through a little notch in the side. and then can secure that gun box to the frame underneath the seat in a car, which is great because if the family, if the person is carrying a gun, has a concealed carry, and goes somewhere where they're not allowed to bring in a gun, we don't want them just throwing it in their glove compartment or throwing it under the seat. This would allow them to lock it up in their car. Also, you know, if we have people who are having some housing insecurity and moving about and maybe staying in a hotel or a shelter, they can secure this with the cable to a piece of furniture or something that can't be moved, and secure their firearm in that way. So we felt like this was a really versatile option. These particular boxes were key. So again, not storing the key with the box because that completely loses the whole concept of preventing access. So making sure that the key is kept separate. There's also ones available that have a number combination that are very similar to this as well. So that was just our pilot, and I think it's really taken off. We're really excited about the work that we've done so far and excited about the next phase, which is you all helping to spread our message. So we're going to hold on questions right now. I do see a question about the resources, and yes, those are all available on the website, as well as some little modules. So we do kind of an overview of the program, which I've already done, and then we've broken it down into focus more on younger children and then focus more on our teens. So all of those resources are available for you on the Ohio AAP Store It Safe website. So that wraps up my section. I am really excited to turn it over to two of my colleagues who I cannot imagine clinic without. Ty Schneider is one of our integrated psychologists in our primary care clinic, and Amy is our social worker. And these two do absolutely amazing work. So Ty, I'll turn it over to you.
Great, thank you. So we're going to shift topics just a little bit. We're going to talk a little bit more about the rising mental health needs and the importance of screening for suicide with the youth that you are seeing, and also hopefully give you some tips and ideas about what screeners you might be able to use, but also some recommendations and kind of brief interventions that could be delivered in a short visit or in a primary care setting. Next slide. We have no financial relationships or conflicts of interest to disclose. These are just the objectives. I'm not going to go over them. We have a lot to cover. This is a lofty goal, so we're going to try and review and hit on all of these objectives today. Next slide. All right, so it's time to participate. So I want you guys to actually go to www.menti.com and enter that code, and we're going to do a quick word cloud. So I want you to describe 2020 in one word. I'm going to share my screen. And as you enter them, they should hopefully pop up here. So go ahead, grab your phone, go to the website, enter that code, and we'll see if this works. Crazy. I agree, good one. Anybody else? Maybe it's not working. Stressful. Yeah, unpredictable. Yes, definitely a year of uncertainty. Very prolonged, chaotic, scary. Yeah. I mean, you can see the themes that are coming with this word cloud. There's a lot of stress, there's a lot of uncertainty, a lot of ambiguity, a lot of anxiety. And this is coming from us as adults. Now I want you to try and imagine being an adolescent, being a youth, being a child during this year. It probably exacerbates all of these words that we're finding in this word cloud right now. Awesome. All right, I'm going to stop my screen sharing, but thanks to those who participated. I'm going to let Alex take back over. Thank you. All right, so as you can imagine, we are really facing a mental health crisis. The APA 2020 Stress in America survey really just has been sounding the alarm about this growing mental health pandemic. And just based on that word cloud, we know that we're stressed, that Americans have been significantly impacted by COVID-19, and we have been finding it harder and more challenging to cope with all those associated disruptions and stressors, thinking work from home, remote learning, the fear and anxiety of keeping ourselves safe, keeping our family members safe. Just limited opportunities for socialization and those financial stressors. And then on top of COVID-19, there were a lot of other stressors that happened in 2020, including lots of like a disputed presidential election and lots of civil unrest. So it's definitely been a stressful year, and we know that it's impacting us. Next slide. We also know that this is really impacting those the Gen Z population. So Gen Z adults, who are those youth ages 18 and young adults ages 18 to 24, and also the Gen Z teens. And so as you can see here, about 75% of Gen Z adults are reporting symptoms of depression in the past 2 weeks. Next slide. And for those Gen Z teens, which are those youth ages 13 to 17, they're also reporting a significant amount of stress, and that stress has increased over this past year. And since I put together these slides, NBC News and Challenge Success, which is a nonprofit associated with Stanford, surveyed around 11,000 high school students from across the nation. And overall, students are reporting less engagement and more stress. In fact, 56% reported more stress related to school. And we also know from that survey from that study that these stressors are impacting females, more females compared to males, and impacting students of color more compared to white youth. And so as you can see on this slide, these youth are reporting less motivation, of course, a decline in participation in extracurricular activities. They feel like they're learning less, and they're having difficulties focusing and concentrating. We also know that there's a significant impact in sleep. And so we might imagine that sleep has increased, or that our teens are getting more sleep during this pandemic because maybe they're not having to wake up for school as early, but that's really not the case. Based on the Challenge Success survey, adolescents are sleeping around 7 hours a night or less, which we know is just not enough. Next slide. We also know that this is impacting how our youth are thinking about their future and feeling like it's really hard for them, near impossible to plan for their future, and that their plans are being severely disrupted. I mean, I'm thinking about some of those typical things that happen in the senior year in terms of prom, and maybe even this junior year when we're thinking about taking ACTs and SATs and thinking about colleges and going to college visits, and having those things be significantly disrupted and just not things that are able to happen at this point in time. Next slide. So these are the things that our patients are coming into the office with. This is just the current environment that we're living in, and things that we want to be kind of talking about and discussing when we're meeting with these youth in visits. We know that stress in and of itself is not bad. To have too little stress is not good, but it's definitely not good to have too much stress. We kind of want to find that Goldilocks right in the middle where we have that optimum stress, so that we're actively motivating, we're working on things that we need to, but to have too much is likely to result in some of that burnout, anxiety, depression, anger, irritability, panic, and those types of things, as well as just that exhaustion. And not, when I talk about stress, I like to mention that stress is not necessarily bad. Like, there are good stressors, such as getting invited to parties, getting invited to talk to the Ohio chapter of the AAP is a stressor, but it's definitely a good stress. So we want to make sure that we're not just using stress as a negative thing. Next slide. This is just different types of stressors. Usually when I'm talking about stress, I kind of think about it impacting 4 different domains. There's physical stress, there's emotional stress, there can be social stress, which we've definitely seen a lot of during this COVID-19 pandemic, and as well as some cognitive stressors. Next slide. when you're meeting with younger children and adolescents, we want to be aware of some of these signs of stress. And so for those younger kids, there's definitely that restlessness or hyperactivity. They might be a little bit more whiny or a little bit more clingy, or just have some more demanding behaviors, oppositional non-compliance, tantrums, those types of things. They might also be experiencing stress in more physical ways, having a hard time with falling asleep, difficulties with stomach aches, or even kind of regressing a little bit and doing things that they used to do when they were quite a bit younger, they might have started to do again. For adolescents, we're seeing kind of more symptoms of depression, that sad mood, maybe that increase in withdrawal, changes in appetite and sleep, those feelings of hopelessness, and maybe just more irritability. They also have those physical symptoms, which can include abdominal pain, headaches, or sometimes that chest tightness or chest pain. Next slide. So what do we want to do about this? And what can we do about these rising stress levels and the mental health crisis that we're kind of now facing? As health providers or as caregivers, parents, siblings, aunts, uncles, one of the best things you can do is just simply ask about stress and really try and screen for depression and anxiety in those healthcare visits that we're providing. After asking, it's really important to validate. So we want to try and avoid any dismissing of that stress or of their feelings. So instead of saying, oh, there's no reason for that, or don't take it too seriously, we want to say something that's a bit more validating, like, man, this really sucks. This sounds like it's so frustrating. One good way to kind of help promote this emotional expression is to just think about high, low, ha, which stands for thinking about what was the best part of your day, the highest part of your day, what was maybe the lowest part of your day, the worst part of your day, and then ending on what was maybe the funniest part of your day, which is something that you could do when you're in the car with your teen, or that parents could do when they're in the car with their children, that could happen around the dinner table or breakfast table, or even right before bed. We are going to, another really important thing that I skipped over is getting onto a good routine and a schedule. That is so helpful. And that's really been one of the barriers to sleep with the youth that were surveyed in that challenge success survey, is that they're just not on a good schedule. The schedule that they were on kind of went out the window as soon as schools went to more remote learning or to hybrid learning. And so it's really helpful to try and work and get back on that schedule, especially as home has become where we're working, where we're doing school, where we're doing our social lives, and bedrooms have even become our school, our place of work or office, and sometimes even our kitchen. So it's really important to try and have a set schedule and times for when you're going to go to bed, having routines with regards to meals, and trying to schedule in some different activities and just time outside of the bedroom, and trying to be creative with that. I know it can be hard in this time right now where things are still closed down, or we might not always be feeling safe and socializing in ways that we used to, but trying to think of new ways to kind of celebrate different occasions or to just socialize just a little bit. Even just getting out of the house and going to the grocery store can be a really good experience and kind of hit some of that behavioral activation that we're going to talk about a little bit more. And of course, we want to try and practice the use of adaptive coping skills, which definitely for stress includes relaxation and more mindfulness-based strategies. And you guys get to participate again. I'm going to share my screen again, and we're going to go to this YouTube video and watch it. Or maybe Alex, you can probably do it.
Yeah, I can pull it up.
It's really short.
This meditation is about awareness of thoughts. Just because you think a thought, it doesn't mean it's true. You are like the sky, and your thoughts are like the clouds. They'll come and they'll go, but they're not who you are. To begin, sit in a comfortable meditation position and close your eyes. Begin to follow the flow of your breath as you breathe in and out. Now, imagine you're holding a big bunch of red balloons. Every time a thought or feeling takes you away from your breath, imagine it as one of these red balloons and gently let it go, bringing your attention back to your breath. It's okay if the same thought or feeling comes back, or you need to let go of many red balloons into the sky. We're not trying to push away our thoughts. We're learning the helpful skill of observing our thoughts and allowing them to be there without getting all caught up in them. Perhaps the next time you notice a thought arise, try thanking your mind for the thought. Just say, "Thank you, mind," and go back to your breath. Notice as you return to school how often your thoughts pull you away from your present moment. Then try to imagine your thought as a red balloon floating up, up, and away into the sky, and go back to your task. Now bring your attention back to your breath, and when you're ready, you can gently open your eyes.
This Mindfully Back to School session was produced by
All
ABC
right.
Radio in collaboration.
So that's actually a part of an app that I often recommend to my patients that I'm seeing here. It's called Smiling Mind, and we're going to go through some more app recommendations towards the end of the presentation. But it was more mindfulness based. So definitely thinking about that non-judgmental awareness and trying to kind of notice your thoughts, but not judge yourself for having them. And so you might notice that you're stressed. You might noticing that you're not doing as well in school as you used to. And that's okay. You can just think about it, label it, and let it go. Next slide. I'm actually going to hand this over to Amy Coleman next. She's going to take over these next couple of slides.
Thanks, Ty. Now I'm very relaxed, so I appreciate that I got to do that mindfulness activity first. So we're going to go over a few definitions. So suicide is death caused by injurious behavior to the self with an intent to die. This is different than a suicide attempt. A suicide attempt is a non-fatal injurious behavior to the self with an attempt to die, and many do not result in injury. So we always talk about with kids, if they think they're going to take, if they thought I'm going to take 4 Advils and they think that's going to cause their death, even though we know that wouldn't, we would call that a suicide attempt if in their mind they thought that would cause them to die. Suicidal ideation is thinking about, considering, or planning suicide. So we know passive ideation is the thought, I don't want to wake up tomorrow, I wish I wasn't here. And, no specific plan or intent to die. Active, this is the thought about wanting to die with the plan, intent to carry it out. Self-injury is different from suicidal thoughts and attempts. These are purposeful acts of physical harm to the self with the potential for injuries or damage, but without the intent to die. So this is different. Kids don't necessarily, they don't want to die when they're self-injuring, but they're in intense emotional pain. So they just want the pain to stop. I've worked with a lot of teenagers who are cutting, self-injury, gosh, it's, it is really grown, and it's such a problem that we're facing with kids. But why do kids self-injure? Why do teens self-injure? It's because they want to distract themselves from the pain they're in, release pain. They don't want to feel numb anymore. They want to feel something. And sometimes I've talked to kids who they feel like they deserve some sort of punishment. So that's another reason they'll self-injure. Although this is different than, suicide and suicide attempts, this is a red flag, and we really need to get these kids the help that they need because it could lead to a future suicide attempt. Next slide. Suicide was the second leading cause of death for youth ages 10 to 14. These slides, just let this sink in with you. Death rates from suicide for kids aged 10 to 14 years jumped by 178%, 178% from 2007 to 2017. And teenagers aged 15 to 19 years experienced a 76% increase over that period. Next slide. We've already talked about this, suicide deaths by method. So Dr. Denny, they were talking about how firearms is the leading cause of suicide death. After that, it's suffocation, poisoning, and then other means. Next slide. We have some information about Franklin County. Over 20% of youth suicides in Franklin County were death by self-inflicted gunshot wounds. Nearly half of all completed suicides in Franklin County were due to the death by firearms. And this one is also really sad to me. Less than 50% of youth with a known mental health diagnosis were in treatment at that time of completed suicide. So we have a lot of kids who have the mental health diagnosis but aren't getting the treatment that they need. So we really need to advocate and really work harder to get these kids the treatment that they need. Next slide. True or false? Talking or asking someone about suicide may put the idea of suicide in their heads. I think you have to push the button for the next, so those show. Okay, so we know that's false. So I talk to parents all the time. After we do a safety plan, I'll say, if you notice your child seems really depressed, if they seem their mood's lower than normal, it's okay to ask those questions. Are you thinking about hurting yourself? Are you having thoughts about suicide? There's still that belief, that myth that people who, if you ask about that, I hear that from parents a lot. Like, I don't want them to start thinking about it. I'm gonna put it in their head. That's actually the opposite. I talk to parents about, if a kid's thinking about it, they're thinking about it. And when I was in counseling, when I would ask about suicide, a lot of times I could see the relief on their face and sometimes the stress come out of their body. You know, they just, you know, like if you're having that thought and it's so difficult and causes so much pain, that when somebody finally asks you that direct question and you get to talk about it, that's really important to teens, to kids that are thinking about it. And I tell parents, really, it's one of the best things you can do as a parent, because you're saying, I can talk about anything, no matter how uncomfortable this conversation is. I care about you and I can talk about this. The other one, if someone really wants to kill themselves, there isn't much anyone can do to prevent it from happening. We know that's false also. We know that people who are thinking about suicide have a lot of ambivalence about death. They do not necessarily want to die. They just want the unbearable pain to stop. So it's really important that we talk to kids about there's help. In the suicide prevention program I was in, we talked a lot about, you know, taking care of your mental health like you do your physical health. So we talk about, if you have a heart disease, you would go to the doctor and take medication. Same with mental health issues. If you have depression, you would go to a counselor and may or may not take medication. So it's really important that kids understand that it's, you know, suicide is preventable and depression is treatable. So another thing I talk about when kids come into our primary care and I complete a risk assessment is, you're not going to feel like this forever. This is temporary. You're not going to feel this bad forever. So really kind of getting that message across that you're not going to feel like this. And it kind of goes along with what they were talking about with lethal means. There's a lot of ambivalence with suicide. And if these kids can't get to firearms and things like that, then suicide attempts will decrease. Next slide. Majority of kids think providers should ask them about suicidal thoughts. In this research, it says 98% thought that was true, that providers should ask them about their suicidal thoughts. And then this was a smaller study with parents. Parents do not think their children should be asked about suicide by providers. That's false. It says over 70% thought that kids should be asked at the doctor's office. You know, take that with caution. It was a smaller study, but it is hopeful that parents are thinking we should be asking these questions. Next slide. So we're not going to discuss it. So the elephant in the room. So we really, as medical, you know, as medical professionals, mental health counselors, you know, we all have to do a better job of asking those direct questions, talking about mental health, asking directly about suicide, self-injury. It's really important that we do this. So we're going to show a quick video that we used to show in our parent night for our Signs of Suicide program. I really like this video because it just talks about how important it is that we ask these direct questions.
Just like anybody else.
Maybe more than anybody else.
I can be hard to figure out.
And I like my privacy. I don't want you looking over my shoulder all the time.
But you know your kid better than anybody else. And if you think he's acting different than usual,
Acting really down, crying all the time for no good reason,
or getting really mad, not able to sleep, or sleeping too much,
Shutting her friends out or giving her stuff away.
acting reckless, drinking, using drugs, staying out late,
Suddenly not doing stuff he used to love.
or doing stuff that's just not like him.
it might be nothing to worry about. It might just be high school.
Or it might be something more. He might be depressed. Not just feeling down, really depressed.
It might be that your kid is thinking about killing himself. It happens. More than you think. More than it should.
And people say, I had no idea.
I thought it was just a phase he was going through.
I never thought she'd do it.
I wish he'd come to
I
me.
wish he'd said
I
something.
wish I'd said something.
When it's too late. So if you think your kid's acting different, if she seems like a different person, say something.
Say, what's wrong? How can I help?
And ask straight out. Are you thinking about killing yourself? It doesn't hurt to ask. In fact, it helps.
When people are thinking about killing themselves, they want somebody to ask. They want somebody to care.
Maybe you're afraid you'll make it worse if you ask. Like, you'll put the idea in their head.
Believe me, it doesn't work that way.
It doesn't hurt to ask. In fact, the best way to keep a teenager from killing herself is to ask, are you thinking about killing yourself?
And what if they say yes?
Or maybe.
Or sometimes,
Well, here's what you don't say.
that's crazy.
Don't be such a drama queen.
You're making too much of this.
That boy's not worth killing herself over. That's not going to solve anything.
You're just trying to get attention.
You're not going to kill yourself. What you do say is,
I'm sorry you're feeling so bad. How can I help? We'll get through this together.
Let's keep you safe.
a lot of people think about killing themselves, adults and kids. Most of them never try it, but some of them do. So if your kid says,
I'd be better off dead. I can't live with this.
I'm gonna kill myself, take her seriously. Find someone she can talk to about it. Someone who knows how to help.
Sometimes kids want to kill themselves because something happened. A breakup, a failure. But sometimes it goes deeper, and it's not going to go away by itself. Get some help. Talk to your doctor.
Or a counselor at school.
Or your minister.
But don't just let it drop.
And make sure that your kid always has someone to turn to. Someone he trusts. Make a list together, right then. 3, 4, 5 names.
Put a suicide hotline number on there too.
Have him keep that list in his wallet, so he always knows where to turn.
Make sure your home is safe. If you have pills she could use to hurt herself, lock them up.
If you have a gun, don't just lock it up. Get it out of the house. Bullets too.
And one more thing. If you think your kid might be about to hurt himself, don't leave him alone.
Take him to the emergency room.
Call 911 if you have to.
We all have our ups and downs, but sometimes it's more than that.
If you think something's wrong, the only way to find out is to ask. Ask straight out. Are you thinking about killing yourself?
Don't wait until you're sure. Trust your gut, because it never hurts to ask.
And it can make a big difference. All the difference. In your kid's life.
Okay, I just really like that video because I think it really talks about the importance of us asking those direct questions. So now I'm going to turn it over to Ty.
All right. So as we can tell, sometimes this is the elephant in the room and we really do want to ask about it. So next slide. It's so important to screen. We know that about 1 in 4 high school students report experiencing suicidal ideation during any given year, and about 1 in 13 have attempted suicide. Most youth who complete suicide actually met with a health provider in the year before their death, and about 50% of primary care providers have had a patient attempt suicide in the past year. Additionally, over 80% of youth with a prior suicide attempts go unrecognized or are not known by the PCP. And this is oftentimes because we're not screening or not asking about it. We know that when we screen, there is a fourfold increase in detection of suicidal ideation. Next slide. And primary care is really a great place to try and get these screeners up and running, although it's great to have them in all of the specialty settings. But we know primary care is a place where patients and families often feel the most comfortable. Adolescents are more comfortable discussing suicidal ideation or mental health concerns or even other risky activities with their pediatrician. And it's a place where families feel comfortable going. They know where it is. It's oftentimes located in their community or in their neighborhood, and they have more familiarity with it. We also know that there's better adherence. About 80% of children see their PCP once a year, and this is a lot higher than seeing other subspecialties or other providers for treatment. We also know that screening in the primary care setting is really acceptable to patients and families, as those true-false questions really indicated, and it's also feasible. We know that there are places who are doing this screening and where it's really working. Next slide. I also like to point out that really, kind of like it or not, PCPs are often the first line mental health providers. You're our de facto mental health providers. And so it's another really great place to screen because you're the ones that they're going to come to first. So for thinking about particular screeners, I always like to point out that it is important to screen for both depression, anxiety, and suicide. If you're just screening for depression, you might be missing those kids who are not currently experiencing depressive symptoms, but are still having suicidal thoughts or have had suicidal thoughts in the past year or two. And it's really important to be able to screen for both. We know that someone can be experiencing suicide, really be clinically depressed or meet criteria for a major depressive episode. So it's important to screen for both. We know too that these are some of the screeners that are available for suicide. And so at Children's, we use the PHQ, the PHQ-9 for adolescents. It's the modified one for adolescents. And this does screen for both symptoms of depression as well as suicide. It takes just about 5 minutes to complete. It is free, and it works and is validated for patients ages 11 to 17. I often give it, we see patients up until age 22, and I think it's totally fine to give it up into those ages too. It's really just a symptom checklist for depression. The Suicide Behaviors Questionnaire is also one of those screeners that would be available. It's for adolescents and adults and takes about 5 minutes to complete and really screens on 4 dimensions of suicidality, including lifetime suicidal ideation or attempts, frequency of suicidal ideation in the past year, any threats of suicide attempt, kind of those preparatory making those statements, and a self-reported likelihood of suicidal behavior in the future. Next slide. There's also the Suicide Ideation Questionnaire, and this is for ages 13 to 18. So just the SIQ is separated by grades. It's grades 10 to 12, and then the SIQ Junior is for those lower grades 7 to 8. The SIQ is 30 items, whereas the SIQ Junior is 15 items, and it's really thinking about the frequency of suicidal ideation. It is proprietary, so it's not going to be as easily accessible if this is something you want to use in your practice. Next slide. And then what we're using as well in our practice here at Nationwide Children's Hospital is the Ask Suicide Screening Questions, or the ASQ, not to be confused with the ages and stages. But this is just 4 screening questions. And if they answer yes to any of those 4 screening questions, then you move down to the 5th question, which is asking about kind of acute, or are you having those suicidal thoughts right now? This is validated for ages 10 to 24. It's really quick. It takes about 30 seconds to complete. There's a whole free toolkit on the NIH website, and it is translated into 13 different languages. The nice thing about this is that it's something that could be, like I said, given really quickly. And we've even trialed giving it to patients around starting at age 8, although it's not validated for those ages. Next slide. This is just a screenshot of what it looks like. You can see that it's asking really direct questions about, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts of killing yourself? And it then does ask if they've ever tried to kill themselves and thinking about how and when that occurred. And then again, if any of those 4 questions are marked yes, then you want to go ahead and ask question number 5 about if they're having any thoughts of killing themselves right now. I will say best practice is to ask this verbally with patients and families, really just with the patient. But here at Nationwide, we're using it on the iPad. It just works better with our flow, and that seems to be working out pretty well. Even though there are definitely some kinks to work out. The other thing that I want to note about the ASQ is that a no response or an I don't know is considered a positive response. So any kind of ambivalence, we want to go ahead and be safe, not sorry, and kind of go ahead and move forward with maybe more screening questions or making sure that we're linking them with appropriate treatments. Next slide. And then finally, the Columbia Suicide Severity Rating Scale is another screener that you could use. This one is free, but it does require some training. It's really only 6 items, although if you go and look for it, if you've used it in the past, you may look at it and think it kind of is a bit overwhelming. But once you have that training and familiarity using it, it really does go pretty quickly. It is looking more at suicide risk assessment. So it's looking to identify those patients who are at greater risk for suicide, and also assesses the severity and immediacy of that risk. And so it's really going through and asking about, have there been prior attempts? Is there prior self-harm? Have there been any preparatory acts and self-aborted attempts, as well as thinking more about what is the frequency of that suicidal ideation and kind of what that looks like. Go ahead, next slide. So just some tips when we're thinking about screening and kind of rolling this out into a clinic or a primary care setting is really to just think about the clinic flow. You want to think about who's going to give the screener, when is it going to be given, where is it going to be given, and thinking really about how can we separate out the parent or the patient and the caregiver. Because we know if we're asking these questions in front of the caregiver, we might get a different response. And so we really do want to try and ask it with the patient just on their own. It can be nice to try and have this built into an electronic health record if possible. We have that now, and it's nice because we now have it built so that we get an alert if there is a positive on the ASQ or the PHQ-9 for those questions asking about suicidal ideation. And this is nice because if you've ever given a screener and then maybe didn't get the results, didn't get the paper, the patient then left, and then you go back and find it later, it's really concerning. And so especially when we're screening for suicide, we want to try and avoid having to follow up with patients and families later. Just because we also know that trying to give them a call and do something like this over the phone, 1, you might not be likely to reach them, and 2, it just doesn't make for that, it doesn't feel as good. And then you kind of run into different concerns or challenges that might include, what if they are currently suicidal? Then I need to tell them to go to the emergency department, and kind of run into some of those logistics. Next slide. I'm going to go ahead and turn it back over to Amy. She's going to wrap it up for us.
Okay. Yeah, and I just want to say about the Columbia, I've done a lot of trainings for that at Children's, and it seems kind of overwhelming, like Ty said at first. There's a ton of words on it, and the language, but once you get used to it, it is really helpful, and it's really considered the gold standard for risk assessment. So, I think it's intimidating at first, but I think it's really a great tool. We're going to go through some risk factors. I'm sure you know many of these. Mental illness. Sometimes we hear people say, why did she take her life? Why did she die by suicide? So a lot of times people are looking for one event that caused a suicide. And so sometimes some of the triggering events are like divorce, parents are divorcing, or breakup with boyfriends, or history of abuse or trauma. But one event does not cause suicide. There's other things going on, most likely mental illness, depression. So not one event causes suicide. There's also a risk factor of substance use, prior suicidal behavior. If there's prior suicidal behavior, we know there's increased risk of future attempts. Suicidal ideation, the severity, plan, or intent, if they have these, the ideations frequently. Access to lethal means, suicide contagion. That refers to, like, so at a school, if a peer or schoolmate dies by suicide, then sometimes, you know, you'll hear of other children dying by suicide. But it's not only the kids who are close to the peer who died by suicide. They've found with research that sometimes it's kids who are kind of on the outer circle of the peer who died by suicide. So we really have to look and be careful, and you know, just watching, you know, the classmates and peers, and you know, everybody responds to grief and loss differently. So we don't want to judge that. We just want to try to get the youth the help that they need. We know being male is a risk factor. We know that females attempt more, but we know that males use more lethal means. Impulsivity and risky behaviors, that's a risk factor. History of maltreatment. The LGBTQ population we're really concerned about. They attempt suicide 4 times more than their straight peers. And this has a lot to do with feeling connected, having that sense of belonging, bullying. So that's a population that we really want to keep an eye on and try to get services in place. History of bullying is a risk factor, a pain or chronic medical condition, and if there's a family psychiatric history. These are all risk factors for suicide. Next slide. So what we really want to focus on is protective factors. We want these kids to have access to treatment. And we've talked a lot today about restricting access to lethal means. And I always just talk to parents about, it's as simple as, if they can't get to these lethal means, suicide attempts will decrease. It's as simple as that. Not as easy as that, but it's as simple as that. We want kids to have strong connections, have social supports, cultural or religious belief, that we know that's a protective factor for some youth. Future goals, reasons for living, use of adaptive coping skills. So that's what we're working on. You know, one time I do risk assessments in the clinic. We do a lot of talking about, you know, what helps you during these times when you're feeling really low, you know. So, you know, we really, and in counseling, that's what we really want to focus on, is creating healthy coping skills. Next slide. Warning signs. We always want to take these seriously. If someone's saying, I wish I was dead, I won't be around much longer, giving important things away, or saying goodbye. Social media, a part of my old job in the suicide prevention program was to do postvention. You know, we would go to the schools after there was a suicide. And a lot of times we'd hear, you know, there were no signs. We had no idea. And at times people would give information about the child's social media account, and there'd be a lot of songs about death or them making statements about death. So there usually are signs, and we always have to take these seriously. Thinking about death or dying often is a warning sign. If kids just don't really care, they're hopeless, not excited about their future. Self-harm, we talked about that, you know, although it's, you know, self-harm is different, you know, there's no intent to die, but this is somebody who's in a lot of emotional pain. So it could lead to a suicide attempt. And withdrawal, we talk about, you know, if you have a child who is really active in music or sports or whatever, and then all of a sudden they don't want to do any of those activities, that's a warning sign too that something's going on. Next slide. Positive screens. So we, like Ty said, we use the modified PHQ-9 and the ASQ at our primary care. So if they have acute SI, we would consider them high risk. That means they're currently having thoughts of suicide. They have a plan, there's intent. We would be sending them to our emergency department at our new behavioral health pavilion, and we would send them there for further assessment. We would really recommend transportation by squad from the primary care to the emergency room. Some parents will say to us, you know, I can get them there safely. I promise I will get them there. Although we recommend squad, if the parents say that, we here at Children's have a form that the parents sign that they understand and that they will get them there safely. Next slide. Positive screen. So if there is a positive screen, like on the modified PHQ-9, if there's concern for SI, or on the ASQ, there's concern for SI, then either Ty or myself will go in and complete a Columbia. And also we have a list of protective factors and risk factors that we go through with the youth. And then we do a lot on the safety plan. So the safety plan, I'm sure all of you do this. So one thing I talk about with warning signs is with kids, I'll say, how would I know if I'm at your house or I'm at school with you, how would I know that you're feeling so bad that you're thinking about suicide? You know, are you a kid who cries a lot? Do you yell? Do you isolate yourself? Like, how is your mom going to know that you're feeling this bad? So really spelling that out. And it's so important to make it collaborative with the parents. Like, so we're doing this together. Like, they need to know, wow, if he's like in his room and that's unusual, then the mom needs to go in and ask those questions. What can you do in the moment? So it's kind of like, what helps you in the moment? So I always talk to them about the safety plan. So, you know, it goes through a list of steps. And so I always say, let's do this while you're calm, while you're, you know, you're not having thoughts of suicide, because when you're in the moment, it's really hard to think about what works, what helps you calm down. So you're going to talk to them about what helps you. And a lot of times it's listening to music. You know, they'll identify they like to draw, or they text a friend, or go hang out with a friend. So it's having a step of activities that they can try. And if none of those work, then it might mean going to the emergency department. Adults you can go to, it's so important that they at least, I know on our safety plan, it says to have 3 trusted adults that they can talk to. But for a lot of our youth, it's really hard to come up sometimes with 1. So if I feel comfortable that they have 1 that they would definitely tell, then, you know, I'm okay with it. I'd rather they have 3, but if they don't have any, then it's going to be really hard for me, you know, to feel okay about the safety plan. And I might lean towards further assessment. If they say, I don't have anyone, I'd tell. We also talk to them about future oriented goals, 2 things very important to them and worth living for. And we always give them the crisis resources. There's at Children's, we have the crisis hotline they can call 24 hours, 7 days a week. There's the crisis text line, which I've done with kids in session before, where we'll actually practice and text the crisis text line. And I think that if you practice it with them, sometimes it's not as uncomfortable, or they're not as nervous about using it. And so you can text and just say, hey, we're trying this out in case we need it in the future. And they're very helpful, and they send supportive messages back and forth. Calm harm, that's one that deals more with self-injury. The My3 app is one that lists your 3 trusted adults. You also can put your safety plan on that app. And before kids leave our primary care, you know, a lot of times they get this piece of paper, and I have seen kids crumple it up, and, you know, I usually have them take a picture of it on their phone. And so they have it with them at all times. So if they need the crisis line, if they need to think about what can I do, it's on their phone. And we know that most kids have their phone with them all the time. Safety precautions with caregiver, you know, a lot of this has to do with increased supervision or monitoring, checking in, making sure their doors open, you know, having those check-ins, having those hard conversations. Are you thinking about suicide? You know, do we need to go get an assessment? Restrict access to lethal means, and providing, like the crisis line, I always tell the parents, this is for you to call if you're concerned too. You call and say, I'm really worried. They can give you advice on how to handle the situation, as well as the child can call if they need extra support. Next slide. Follow up, just quickly, we just want to make sure that after kids are assessed and we find out, you know, they do need some further mental health treatment, then we would just want to make sure that they're linked with some evidence-based therapy. If it's CBT, DBT, or IPT, we want to make sure they're linked with a counselor who's using some sort of evidence-based treatment. At our primary care, we also, after we identify and complete a risk assessment, we usually have them come back to the primary care in a couple of weeks to reassess their safety. I think this is important too, because the primary care, we found with a lot of our families, it's, sometimes they don't like to go all the way downtown, and we're in the community. And so they feel a little more comfortable coming here, and maybe, our doctors have seen them since they were little. So we want them to come back in to make sure, and at this visit, either Ty or myself will check in with them. We want to make sure they're linked with counseling, because a lot of times we'll do this whole risk assessment, do a safety plan, try to link them, and then we find out, some reason that they haven't gotten there, to those appointments. So we want to make sure, are there any barriers that we can help with? Do they need to go somewhere closer? Do they not know how to do the telehealth? And just things that we can help with, because we want to make sure that they are linked, if, especially if there's any concern of suicide risk. And then also at these visits, we will consider a trial of medication. Next slide. Other interventions, I know when I go over this with kids and I'm like, well, if you sleep and eat well, they're like, whatever, I already do that, but it is free medicine. And, I try to talk with kids about, there's research that if you're getting the right amount of sleep, if you're eating healthy, it does improve your mood. Not always what they want to hear, but behavioral activation, talking back to depression. So kind of fighting back to those thoughts that are telling you, lay down all day, don't do anything, eat a bunch of junk food, talking back to the depression. And that's something we would work on in counseling with these kids. Setting SMART goals. Ty had to remind me what this stood for, but basically what it means is, Ty, do you want to tell me again? I know it's measurable.
Yeah, because sometimes with depression, things can just seem so overwhelming. And especially in light of the COVID-19 pandemic and remote learning, you log on and you're like, oh my God, I'm 20 assignments behind. I'm never going to be able to do this. Close the computer back down. And so you really want to think about, how can we break this down into something that's going to be more achievable? So those SMART goals, some of you probably already know, it just stands for something specific, measurable, something that's achievable or attainable, relevant to the person, and something that's time bound, so that we can kind of go back and check in and say, hey, how's this going? It's not working. Okay, let's revise it. Let's come up with something that feels like it's going to be a little bit more easier for you.
So for example, I knew what it meant, but I couldn't remember what the words were. But for example, it means like, we can say, hey, you need to exercise this week, but let's make it small. Like, how about you take one walk this week, and trying to build off that, because when you set such a huge, broad goal, it's really hard, it's really hard for follow through. So we want to start small, make them achievable, so we see some progress. Distress tolerance. So for example, tip, that could mean like using the ice cubes, like if you're thinking about self-injury, using the ice cubes, instead of self-injuring, intensive exercise, paced breathing, progressive muscle relaxation. So we'll talk to kids about like starting at the top of their head and, like squeezing squeezing their muscles for 5 seconds and letting go, and going from the top of your head to your feet to see how they feel after they complete that. And mindfulness, we do a lot of mindfulness with kids, trying to learn to stay in the moment. There's so many apps for that and activities online that you can find that are really helpful. And accepts, that talks a lot about, just comparisons, like, thinking other people, do I really have it the worst? Other people are having problems too. And so trying to come from that viewpoint. Next slide. Apps, there's so many great apps out there. Virtual Hope Box, Smiling Mind, Insight Timer, CBT Coach, Stop, Breathe and Think, Breathe to Relax, Mind Shift. Personally, I love Headspace for anxiety. The first 10 sessions are free, and you can listen to those over and over. And they have really cute animations that kids can watch. Like, it talks about your thoughts going by and not jumping in and reacting to your thoughts, but like kind of like a traffic jam and just watching the cars go by, kind of like watching the clouds. But they have great animations that, for visual learners. So that's a great one too.
And these are all free.
Yep.
And CBT iCoach is really for insomnia, but it has some really good like mindfulness relaxation strategies on there.
Okay, next slide. And then we always want to make sure that the families before they leave the clinic have crisis resources. We use our crisis line a lot, the crisis text line we talked about. There's a Spanish suicide prevention lifeline, net care for kids over 18, or adults, I guess, over 18. So we always want to make sure that families have those resources and can access those if they need it.
Great.
And then,
before we talk about PMP resources and in wrapping up, we wanted to take this time to answer any questions from you, and that can be from Dr. Denny or Dr. Goodeman as well. So please let us know if there's any questions in the chat box, and then we will wrap up the training. Thank you everyone for speaking, and we really appreciate the time that you took to share this information.
I just wanted to say also big thanks to all of you who have been taking the pledge throughout this session. We really appreciate that. And I know that Alex will be helping provide those links to resources when all of this information goes out.
Great, thank you. Well, if there's not any questions, if questions come up after the training, after I send out the follow-up information, you can let us know and I can make sure that they get those questions. Like Dr. Denny said, I will send out the slides. You'll be able to access the recording. I'll send out the resources that Dr. Denny and Dr. Goodeman spoke about, so you'll be able to access all of that. Great. So as far as the PMP resources, these are just a few examples of some of the resources that we have available. Like I said, they're age specific and then topic specific, and we have some new handouts that are going to be launched soon. So you can also access those. And then you can fill out the survey to receive your CME and MOC credit. This will also be sent out in an email, so don't feel like you have to take it right this moment. And then I also wanted to remind you all of the toolkit, and you can sign up for the PMP toolkit, and that information will be sent out in the follow-up email as well. Thank you everyone for joining. Thank you again to our speakers for sharing this great information, and thank you to ODH for their support with this training. With any questions, comments, anything that you need, please feel free to reach me at my email address or the phone number, and I will send out the survey for you to receive your credit for the training, as well as all the additional resources. Thank you everyone for joining. We really appreciate it, and we hope you have a great rest of your week.